Welcome to today's webinar presented by Robert Wood Johnson University Hospital, Somerset, in conjunction with Friends Health Connection. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Our topic today is Facing Ovarian Cancer, a Woman's Guide to Health. About 22,000 women will be diagnosed with ovarian cancer this year in the United States, according to the American Cancer Society. It is the fifth leading cause of cancer deaths in women. During today's webinar, we will learn more about ovarian cancer, risk factors, symptoms, causes, diagnosis, and treatments from our special guest, Dr. Ruth Stephenson, who is a fellowship-trained physician specializing in gynecologic oncology. She recently joined the medical staff at Robert Wood Johnson University Hospital, Somerset, and sees patients at the hospital as well as Rutgers Cancer Institute of New Jersey in New Brunswick. We will begin our webinar with about 20 minutes of a moderated discussion, and then we will open the forum to questions and answers from our audience. So thank you again for joining us, Dr. Stevenson. So let's first begin by having you tell our audience a little bit about yourself.
Sure. So thank you for having me. I think that this is a wonderful opportunity to be here and to talk about ovarian cancer. You know, it is GYN Cancer Awareness Month, so I think that this is we're at the end, but this is important. So I am a board-certified GYN oncologist. I think a lot of people aren't sure exactly what a GYN oncologist is. So basically, I did a 4-year OB/GYN residency. Oh, Deirdre's emailing me. And then went on to a 3-year subspecialty fellowship at the University of California, Davis, where I was further trained in cancer surgery, specifically for GYN cancers, or cancers that come from the uterus, ovaries, and cervix. I was also trained in chemotherapeutics and coordinating just comprehensive cancer care for GYN malignancies. So I no longer deliver babies. So we're a subspecialty of OB/GYN. A little bit about myself. I'm originally from upstate New York. I went to college in Rochester. I did medical school in Long Island. I actually did my OB/GYN residency at St. Barnabas in Livingston, in New Jersey, and then went out to California for my GYN fellowship. I've been out of fellowship training now for 5 years. I did spend some time up at the northern campuses, so I worked at St. Barnabas as a GYN oncologist, Claremont, Jersey City. I was recruited to the Cancer Institute about 4 years ago, and now I'm fortunate enough to see patients at Somerset. I live in Bridgewater, so I'm about 8 minutes down the road, so I can stop at Costco on the way home, but I'm really happy to be at Somerset, and I'm looking forward to taking care of our GYN cancer patients at Somerset University Hospital.
Well, thank you so much. And thank you once again for joining us.
Of course.
So let's also start with providing everybody with an overview of ovarian cancer. If you can tell everybody a little bit about that and what happens when somebody is diagnosed with ovarian cancer.
Sure. So, as you were saying, ovarian cancer, we have about 22,000 cases in the United States. So overall, in general, a very rare cancer. It's about the 3rd most common type of GYN cancers that we treat. If you look at the statistics, about 1 in 80 women will get an ovarian cancer versus 1 in 8 women who will get a breast cancer, which is a much more common female cancer. Unfortunately, ovarian cancer is very lethal, or has a high mortality rate, and that we often diagnose these cancers at a much later stage, and they're more difficult to treat, and are actually one of the higher death risks for cancers in women is ovarian cancer. The ovaries are where the eggs are made. It's part of the female reproductive organ. And that's where the ovarian cancers can arise. And they can start as very small abnormal cells and then start spreading very quickly, which is why, unfortunately, we don't diagnose them until a much later stage.
So what are the causes of ovarian cancer?
So about 70 to 80% of the time, they're considered sporadic, or we don't know what happens, but the cells on the ovaries become abnormal and start growing very quickly. about 20 to 30% of the time, these cancers are actually caused by a genetic mutation or a mutation in your DNA that is passed on from your parents to you, or a family hereditary cancer syndrome. You know, we know that older women get ovarian cancer, so age is a risk factor for getting ovarian cancer. The average age that a woman is diagnosed with ovarian cancer is 63. Unfortunately, we do see some rare types of ovarian cancer in younger women. As I was saying, other risk factors for ovarian cancer other than age can be genetic syndromes, things called the BRCA1 and 2 gene. Those are genes that are passed through families that increase your risk for breast and ovarian cancer. Angelina Jolie was actually a carrier, so I don't know if anyone followed her story or her journey dealing with that genetic mutation. And there's certain other risk factors that are often controversial, but we think that, you know, going into menopause later or getting your period earlier can increase your risk of ovarian cancer. There's some data about obesity increasing your risk of ovarian cancer. There's certain syndromes called polycystic ovarian syndrome, which can be linked to ovarian cancer, and things like endometriosis, which is a chronic benign condition, can also increase your risk for certain types of ovarian cancer.
So there are risks and then there are causes, correct? So
Correct.
the causes you said were sporadic. I just want to, right?
Yeah.
All right. So, but while these are risks, there's really, I guess it's really not really known to be any one cause.
Right. Most
Okay.
of the
I just
time
wanted to
don't know.
clarify.
Yeah.
Thank you. So can ovarian cancer be prevented?
So we know that the best prevention for high-risk patients, right? Patients who have a family history of ovarian cancer, or patients that carry a gene that will increase their risk for ovarian cancer, it can be prevented by performing a surgery to remove the tubes and ovaries. Some other preventative strategies or things that can reduce your risk of getting ovarian cancer are being on a birth control pill, having a tubal ligation, and also certain types of screening tools that we use can decrease your risk of getting an ovarian cancer as well in high-risk patients.
It's very, very interesting. So just briefly, what are some of those tools that can help to prevent ovarian cancer, if you wouldn't mind?
So, you know, I think really from a prevention standpoint, the most definitive would be to remove the tubes and ovaries in high-risk women. To screen high-risk women, we use ultrasounds of the female organs, ultrasounds of the ovaries to look for masses or cysts that may be abnormal. We can also use something called a CA-125, which is blood work that is not a yes or no work for cancer, but can be used to screen women if it's abnormal, to say maybe we should look at this ovary a little bit closer or do some follow-up imaging or something like that.
So what are the symptoms of ovarian cancer? How would women know if they may potentially have an issue?
Yeah, so ovarian cancer symptoms can be very vague and non-specific, which is another reason why we often don't catch these early enough. Women can just have some discomfort when they're urinating, or feel some abdominal bloating, or their appetite can change, or they can feel a little nauseous after they eat. And very often I see women with ovarian cancer who've seen stomach doctors and bladder doctors and general GYNs because they just have these sort of non-specific complaints, and no one can really kind of delve into or narrow down what's going on until there's some imaging. But the symptoms are very non-specific, but most commonly we see women complaining of some sort of abdominal bloating, discomfort, changes in appetite. Some women can have some abnormal vaginal discharge or bleeding, but they can be very non-specific, unfortunately.
Very interesting. So then how, I think you started to mention this, but how do you diagnose it? So somebody comes to you, they have these non-specific symptoms. They maybe sense something is wrong, but don't know. So then what do you do? How do you diagnose it?
So typically it starts with an imaging test. Often an ultrasound or a CT will look at, the ovary and say, yes, there's something abnormal on there, like a cyst or a mass, or they may see fluid in the belly. The only way to definitively diagnose an ovarian cancer is to actually remove the ovary with the surgery and have another doctor, what's called a pathologist, look at the ovary under a microscope and say, yes, there's a cancer there. Because a lot of women will get cysts on their ovaries or, can have these things grow on the ovaries that aren't necessarily a cancer. We can also use that blood test, the CA-125, to determine whether or not we think an ovarian cyst may be at risk for being a cancer. But ultimately, a cancer diagnosis is made once the ovary is removed and looked at under the microscope.
So then how do you treat? What are the treatments or treatment options for ovarian cancer?
Yeah, so almost all ovarian cancers are treated with a combination of surgery and chemotherapy. So often the first step is to take a woman to the operating room, remove the ovary. Sometimes we do a full hysterectomy. And if there's evidence of cancer that's spread other places, then we remove those tumors at the time of that surgery. Because ovarian cancers behave very aggressively and have a high risk for coming back, almost all ovarian cancers are treated with what's called adjuvant chemotherapy. Chemotherapy is medication that goes through your veins that kills any little cancer cells that may be floating around in the body or in the abdomen after surgery. What's very exciting in treatment for ovarian cancer are new targeted agents, something called PARP inhibitors that have been FDA approved for use in ovarian cancer. And they have shown really great response rates for cancer and also prolonging women's survival by using these new drugs or these new targeted agents. So chemotherapy is a medication that treats all the cells in your body, good cells, bad cells. But when we use these PARP inhibitors or these targeted agents, they target a specific mutation in the cancer cell and spare the rest of the good cells. And so it's a really novel strategy for treating cancers. We're very fortunate to have these drugs available to our ovarian cancer patients. And they've really changed the way that we're taking care of ovarian cancer patients in both the maintenance and surveillance setting. So there's lots of exciting things on the horizon. I think in general, ovarian cancer, because it's diagnosed at such a late stage and can have such a high mortality rate, or a lot of women die of this disease, over the last 5 years with these new medications and new drugs that have been developed through clinical trials, we've been able to keep ovarian cancer patients alive a lot longer. And so it's very exciting in our field to be able to have these targeted agents for our ovarian cancer patients.
So thank you for bringing that up. So you mentioned these medications as new innovative treatments. So what are these medications and who would qualify for them?
Sure. So they're called PARP inhibitors. They're a pill that works on a specific mutation in the DNA that most ovarian cancer patients have, or a high number of ovarian cancer patients have. Not everyone is a candidate. They were initially studied in women who have a BRCA1 and 2 mutation because they have something wrong with their DNA. They have a DNA repair mechanism that's faulty, right? It's broken. And so these pills work on that faulty mechanism to kill the cancer cells. And so we were initially just using it in the BRCA1 and 2 mutated ovarian cancers. But now, even in the last 6 months, we've been looking at it in all ovarian cancer patients. So a typical treatment for ovarian cancer includes a surgery where you either have a staging surgery, a hysterectomy, removal of metastatic lesions, and then you get chemotherapy. And then we would go into this kind of watch and wait. Like, we're just going to wait for your cancer to come back because we know it has about a 60 or 70% risk of recurrence. But now we have these targeted agents or these pills that women can take during that surveillance period. And it's been shown to increase the amount of time before their cancer comes back. And we have data showing women living 5-10 years on these PARP inhibitors without their cancer ever coming back. So it's really sort of revolutionized how we're monitoring and maintaining our ovarian cancer patients.
That's great. Thank you. So for women of childbearing age, what options do they have to preserve fertility?
Yeah. So In young women, there are some rare cancers that we can diagnose. And so, my approach in a young woman who may not have children, who wants to preserve her fertility, there's options to do what's called a fertility sparing surgery, which is where we just take the abnormal ovary. We'll do what's called our staging procedure, which is sampling tissues from around the abdomen and pelvis to make sure the cancer hasn't spread anywhere, but still preserve her uterus and ovary so that she can go on to have children once the ovarian tumor has been removed. We also work very closely with infertility specialists in our young cancer patients, and that if we are planning to do a full hysterectomy, I'll often send them to an infertility specialist to discuss their reproductive options, things like oocyte preservation or freezing eggs, or talking about options for gestational carriers. But I think, in any young woman without children who desires future fertility, our goal at the time of surgery is to preserve normal ovary and uterus and just take what we need to take. The other thing that we run into fertility issues with is young women that do have the BRCA gene, and we recommend removing tubes and ovaries so that they don't get an ovarian cancer in their lifetime. We can do what's called a staged surgery, where we may just remove the fallopian tube and leave the ovary. We have more and more data suggesting that some ovarian cancers actually come from the fallopian tube. And so we're able to preserve their fertility by just removing the fallopian tube. They can have children and then ultimately have the ovaries removed. So there's lots of options, and it's often a multidisciplinary approach for our young women involving infertility specialists to preserve their fertility.
Great, thank you. I know that comes up quite frequently, that question among our younger women. And so, we talked about, if you're diagnosed, we talked about how to diagnose, the treatments, there's so many new innovations. So, is the message that is ovarian cancer curable? Sounds like, how I guess, what is the, success rate with all these new treatments?
Yeah, so, historically, the overall prognosis for an advanced ovarian cancer, which is about 70% of our patients presented at advanced stage, was that there was a 50% death rate at 5 years, which is awful, right? And so we, as physician scientists and in the lab here and clinical trial folks, we've been all working to try to improve those survival rates. So I often tell patients that, we have certain data from historical data, but in the last 5 years, and there was actually a couple papers published recently, that there are more and more long-term survivors of ovarian cancer. And we often approach ovarian cancer almost like a chronic disease, knowing that it's a high risk for recurrence, but we have better and better options for treatment, and that a woman may need intermittent treatments throughout their life to help control the disease or make it go away again with chemotherapy or another surgery. But I think that, I'm hopeful, and us that take care of ovarian cancer patients are very excited about all of the new options that we have to keep our ovarian cancer patients free of disease. But they always will need surveillance. They'll always need monitoring with a GYN oncologist, and may need intermittent treatments throughout their lifetime to help control the disease. But, we have a lot of exciting new things that we're investigating and our options for our patients.
That's great. And just my final question before I open it up to our audience for questions is, when you talk about treatments, there are various stages of ovarian cancer. So if you can describe what those stages are and how, if early detection may impact prognosis, that would be great. Can you share a little bit with our audience?
Sure. So, stage one, a stage of cancer basically describes where the cancer has spread. And so stage 1 disease means that it's just in the ovary, right? And those are the patients that do the best because we catch them early, we get the tumor out, and they have a low risk for the cancer coming back, and they have good overall survival or prognosis. Unfortunately, because women have these non-specific symptoms and these tumors can grow fast, we often diagnose these women at what's called stage 3 disease, which means that it can spread around the abdominal and pelvic cavity to multiple places along the intestines or the liver or the diaphragm, which is, all these tissues that line your organs. And so 70% of the time we diagnose women at stage 3 disease, meaning it's left the ovary and spread around the abdomen. Stage 4 disease is unfortunately when it's gone even further into either the lungs or lymph nodes in the groins or other places that we consider distant metastases or far away places that the cancer has spread. And those, patients tend to not do as well. As far as, screening, it's difficult because for cervical cancer, we have the pap smear, right? And so we can screen the entire population with a pap smear to help prevent cervical cancer. We do not have good guidelines saying that doing ultrasounds or CA-125s on every woman in this country is going to help us prevent ovarian cancer, catch ovarian cancer sooner. Certainly in like the high risk population patients with genetic mutations or family history, we would do screening ultrasounds, but obviously it's better when we catch them early. They're more treatable when we catch them early, but we don't have a good screening tool yet. And there's still a lot of ongoing studies looking at ways that we can screen effectively and cost effectively screen women for ovarian cancer.
How do we reach your department? So if you want to address that one, how do we?
Yeah, so I mean, actually, since we've had this big merger, there's actually a Cancer NJ number, and I wish I probably should have.
Well, I was going to say they could call
readily available, but I can give you intake numbers. There's a Cancer New Jersey number. So because we're part of a large network, and we are trying to provide quick and good access to cancer care for all of the patients in New Jersey. So I see patients at Somerset, I see patients at the main campus. We have a cancer intake department through the system that can help navigate patients to what's most convenient. If it's easier for you to see me at Somerset or at the main department. Do we have those numbers?
I was going to say that they are welcome to call the Steeplechase Cancer Center at Robert Wood Johnson University Hospital, Somerset. I have two numbers. The main hospital number is 908-685-2200, and then you could just ask the operator to patch you over to Steeplechase. Online, there is also a number, 1-866-742-5762. And certainly I'll give information at the end for more information about Robert Wood Johnson Somerset in general, that people will be able to log on to and get as well. So thank you. And then do you offer support for caregivers? Somebody, unfortunately, a patient who has, who's ill, that impacts their loved ones and obviously their caregivers. So what do you offer?
Yeah, so we work very closely with nurse navigators and social workers. There's online and in-person support groups. I think, one of the most important things is, I think, as a caregiver is to take care of yourself. And often I'll tell family members, I'll make sure that they're sleeping, that they're resting, that they're getting support, not trying to do it all. But we do have a whole team, both at Steeplechase, at the Cancer Institute, where we work very closely with our nurses, social workers, and hopefully are able to provide patients and their families with all the support that they need while getting their family member through cancer diagnosis.
Thank you. And while you were talking, I just got the information on the number they can call to reach your department. It's 1-844-CANCER-NJ. So thank you for that. So we have another question from one of our audience members. For a 60-year-old having surgery for ovarian cysts, what are the pros and cons to remove the ovaries? And this individual or patient also has osteoporosis.
Yeah. So, I think there is data even after menopause. So menopause is when the ovaries stop making estrogen and progesterone. And that's when women start to get at risk for things like osteoporosis, which is thinning of the bones due to lack of estrogen. At 60, the ovaries are probably not making much estrogen, but there is data that even up to 65, there's benefit for cardiac and bone health for women to leave their ovaries in. That being said, if they are abnormal ovaries or ovaries that have a cyst or a mass on them, then I think that that takes priority over the hormonal benefits of keeping ovaries in. And I tell women that, you know, if there's a cyst on one ovary and we have to make a decision about the other after menopause, women who get cysts on the ovaries are at about a 20% risk of getting it on the other one. So leaving that ovary in, you're at risk of getting maybe a cyst on the other ovary or something and needing a subsequent surgery. So I think at 60, even in a woman with osteoporosis, it's reasonable to remove both ovaries because the amount of hormone they're making is very, very low.
Very good. Okay, I'm just looking here. Last call for any additional questions. Okay. Well, if not, then this will conclude today's webinar. We want to thank you for joining us. And please remember that the opinions here today by our medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call 1-888-724-7123. And for more information about Robert Wood Johnson University Hospital, Somerset, please log on to www.rwjbh.org/Somerset. So once again, thank you for joining us, Dr. Stevenson, and thank you, ladies and gentlemen, for joining us, and we hope you have a very nice day.